So today's guest is Dr. Stephen Hussey, a functional medicine expert and nutritionist known for questioning mainstream narratives around cardiac health and metabolic diseases. With advanced training in chiropractic and functional nutrition, Dr. Hussey focuses on the disease through the lens of energy metabolism and systems biology, asking not just what's broken, but why. This conversation challenges a lot of what we think we know about cardiovascular health, and it's the one you will definitely want to stay for. Stay tuned and please do subscribe and follow, because I am putting in a lot of efforts to bring in the best of the speakers to you in terms of functional medicine, health and wellness, so you have an all-round picture of what health means and how you can take health into your own hands with the available cutting-edge information and technology.
So, Dr. Stephen, I'm so glad that we were able to meet at the Copenhagen Health Week, and then this translated into this beautiful podcast. And it was such a changing moment for me when I read all the pieces that you had written, and all the things that you were doing with regards to heart health and with regards to the focus on functional cardiology, challenging the conventional wisdom and everything that's around today. So let's start with your journey. You're a chiropractor who became one of the leading voices in functional cardiology. And that's not a typical path, right? What was your moment or experience that made you realize conventional approaches to heart health weren't telling the whole story?
Well, I mean, I started at a young age for me. I had a lot
Yeah.
of chronic conditions as a kid.
Okay.
And so those chronic conditions, those inflammatory conditions, were what drove me to understanding that, medicine wasn't able to help me with those things. And so once I was able to change my lifestyle and get rid of those conditions I had as a kid, which was like asthma and allergies. I used to break out in hives, had irritable bowel syndrome, all those types of things. Once I was able to manage those conditions without medicine and get rid of them, then that was kind of my signal that, hey, maybe medicine doesn't have all the answers. And then what got me interested in heart disease was that I'm type 1 diabetic. I was diagnosed as type 1 diabetic at the age of 9 years old. And so that heavily predisposed me to heart disease, which is what I learned over my childhood. And then, yeah, so that pushed me into looking for information about heart disease. And then, despite my best efforts and looking at things from a very diet and exercise perspective and trying to prevent heart disease from a diet and exercise perspective, despite doing that, I had a heart attack at the age of 34.
Mhm.
And so after that, I realized, okay, so there's something missing. I can't explain this based on what medicine was telling me and my current understanding of what causes disease. So I had to
Right.
dig a lot further. And so I kept digging and found a lot of the answers to, I think, why I had a heart attack, what causes heart disease in general,
Mhm.
and was able to reverse things. So I was able to completely heal my heart after the heart attack, no heart failure.
Mhm.
The conduction signal is now normal. I was also able to prevent heart failure, like I said, but also I reversed plaque in my body. I reversed plaque in a peripheral artery in my leg, and I've been able to keep my coronary arteries clean despite having cholesterol levels that are astronomically high according to the authorities. So I've done things that cardiovascular wise that medicine and cardiology told me that were impossible, that I couldn't do those things, and I did them
Right.
anyways, and I did them in a very unconventional way. So yeah, that's kind of my story
Right.
and what I've done. So
Right. So you are actually telling me that plaque is reversible. Is that actually true? And because I know as a doctor that we are taught that plaque is irreversible, and the only thing that can prevent you from dying from a plaque is a stent, right?
well, yeah. So I mean, in my N of one example, plaque is reversible because I did it. Right. So I can't extrapolate that to the rest of the population. I can't say that. But if one person can do it, I think that it's likely another person can do it under the right conditions. So yeah, and stents are things that go in there and they try and open up this narrowing of an artery of plaque, right? And so those are done to try and prevent heart attacks. The
Right.
only issue is that the research is very clear that doing those procedures to try and prevent heart attacks does not prevent heart attacks. You can do those procedures or not do those procedures, and your chance of having a heart attack is exactly the same. And that's just what the literature shows. So it's not really helpful. Now, in an acute situation where someone's having a heart attack, and the heart attack is actually caused by a blockage or a narrowing, then yes, stents can be life-saving. And that was the case for me. But preventatively or elective stent placements are not very useful, according to the literature.
That's really interesting to know because most doctors won't tell you this, right? Most doctors will tell you, yes, you have high cholesterol, you may get a stent placed in order to reduce your plaque, or like for example, when you have a STEMI or an end STEMI, that is nothing but a heart attack, is when maybe 80% of the patients get their stenting done, but then there are also a quite large number of patients that get their stenting done because they have a blockage. Do you think that is a useful procedure?
No, like I said, the literature shows that it's not useful for preventing future heart attacks. They can give some people symptom relief
Mhm.
for about a year, but it doesn't stay. It's not like a solution long term,
Right.
for up to a year. So some people don't even get symptom relief for up to a year. But it all depends. Like if someone does a stress test and they get chest pain and then they do a heart cath, they'll say that the chest pain was caused by, this stenosis they may or may not find.
Mm.
And so, but if there's chest pain without a stenosis, how do they explain that?
Yeah.
And I could explain that, but the doctors can't necessarily do that. Their thing is their protocol is just that procedure, do the heart cath, place a stent if it's necessary. The only
Right.
problem is, like I said, the
Yeah.
stents aren't preventing heart attacks. They're just
Yeah.
not long term. So.
Right. So can you explain me as to why is there a chest pain on a on a stress test if there is no plaque or if there is no narrowing? Why is that even happening? And what is that we're actually missing? Because I know as per traditional literature that if this is your artery and the lumen, we say that the plaque is inside the lumen, right?
Right. Well, and that's not actually the case. The plaque is in the artery wall itself. It's in the intima layer of the artery wall. It doesn't happen like on the interior lining of the artery where the plaque doesn't like grow there and grow in. It grows in the
Yeah.
artery wall, growing like this. And so the theory is that expansion, that plaque, wherever it grows, it narrows the artery, and that creates a stenosis,
Yeah.
and that stenosis restricts blood flow, and
Yeah.
that restricted blood flow will deprive the tissue of oxygen, and you'll start to get chest pain. You'll start to get the same type of pain as if you just weren't getting blood to an area, you'd get pain there, and that's just not true in my opinion. Because the work of Giorgio Baraldi showed that anytime an artery gets to about 70% narrowed, it will build collateral arteries around it to fully
Mhm.
compensate the heart with blood. And I've had some cardiologists tell me that some people develop collaterals, some people don't. But the reality is Baraldi's work, and he autopsied thousands of hearts throughout his career, showed that everybody develops collateral arteries,
Mm.
which means that a stenosis is not going to restrict blood flow. The body will develop new arteries around it, or arteries will grow from the other areas of the heart to help supply the area that's missing blood. And so, but that explains why an elective stent or a bypass surgery are not helping prevent heart attacks, because it's not about blood flow. The body compensates the blood flow by building collaterals. So the real reason we get chest pain has to do with nervous system signaling to the heart.
Mhm.
If you get imbalanced nervous system signaling to the heart, then if we get like a surge of a stress signal or sympathetic signal to the heart without the lesser surge of parasympathetic, which can develop over time, that imbalance, then we get a cascade of events that can lead to a shift in metabolism and heart tissue. It'll shift
Mhm.
away from burning fatty acids to burning more glucose, and heart muscle tissue doesn't like to do that. And so when you start burning more glucose, then you start to build up lactic acid and hydrogen ions, and that's what creates a chest pain. That's what creates a burn. It's a muscle burn, is what it is. Just like the same thing if you go for a run and your leg starts to burn, because it's
Right.
building up, it's burning through glycogen stores and it's building up lactic acid and hydrogen ions. So the same thing's happening in the heart, except it's happening due to an imbalanced stress signal from the heart, which is why, like when people have angina, they walk down the driveway, they exercise, they get chest pain. Why? Because you're increasing the sympathetic nervous system. It's not because you're
Right.
increasing blood flow and it's not getting somewhere. It's because you're increasing the nervous system response. Or we all know that heart attacks and angina are more associated with stressful events,
Right.
stressful times of the year, stressful days, like Mondays or holidays or sporting events. Those types of things, they're all known to increase the risk of heart attacks and angina. So that's why. And meanwhile, over here, medicine is chasing down the plaque and the stenosis because they can treat it, or
Yeah.
they can treat it, so to speak. When in
Yeah.
reality, it's not the actual cause, and they're not actually addressing the real cause. So yeah.
So you just told me about, the actual cause, maybe the sympathetic and the parasympathetic signaling, right? For a general user, can you actually break down that concept a little more, like for a layman, so that because, what does this thing do actually, and what is the actual cause? Because now we're seeing 20-year-olds, 25-year-olds developing heart attacks. And in India, we see people who are in their 30s, 35s dying of heart attacks. Why is this happening? And what are we as doctors missing out? Because, at least we've caught up now on this educating of the patients that, okay, diet and exercise is important and walking is not exercise, right? What are we missing out? What are the cause of these heart attacks?
So again, it all has to do with the way the nervous system is signaling to the body, but specifically to the heart. So the nervous system, we are just big sensory organs or sensory beings, right? We have so many different ways of sensing
Right,
our environment.
right.
There's more than just five symptoms or five. There's more than just five senses, and so that's what we're doing. And so their body's taking in all this information, and it's relaying that information, that sensory information, to the brain. The brain is not changing the signal; it's not deciding what to do with it. It's just receiving the information and interpreting that and sending it out to where it needs to go. And so, if we want to change the way the brain is signaling to the heart, the nervous system signaling to the heart, we need to change the signals that the body is getting. That means changing your environment, and that means a lot of different things. That means your relationships. It means your light environment. It means your diet. It means your exercise. It means your toxin exposure. It means your dental health. It means trauma. It means all kinds of things. We have to change. We have to change those signals if the signals are off. And so when you think about it that way, then we change those signals, then the heart and all the senses, relay that information to the brain, and the brain sends that signal back down to the heart. So depending on what signal the brain is sending to the heart, that's where the balance from the nervous system comes from. And people always talk about, hey, we're in sympathetic or parasympathetic, and that's not true. We're always getting signals from both. So it's more like this seesaw. You're always getting signals from both. And if we get to a situation where we get a surge of stress signal, like in the case of like an acute stress that we experience, we get a surge of stress signal without the lesser surge of the non-stress signal that helped balance it out. Then we can get a cascade of events that happens in the heart that can lead to tissue death. So you can think of it like this. The analogy I use is if you're walking your dog on a leash, right?
Mhm.
So if you're walking your dog on a leash and your dog sees your neighbor and wants to attack your neighbor, and it goes and tries to attack your neighbor, this response the dog is having of the attack, that's the stress signal happening, right? The leash you have the dog on is the non-stress signal holding that. Like the response is still happening, but
Right.
the leash is keeping that from becoming something catastrophic. So if your heart gets a stress signal and it has the stress response signal, it has the leash of the non-stress response to kind of keep it balanced, right? And if that gets inhibited, right, because there are things in our modern way of life that can inhibit that response, inhibit that balance there, that we can get a stress response without the lesser surge of the non-stress response, and that can cause this cascade of events. So what that does is it forces your heart tissue to burn more glucose than it would like to because it prefers fatty acids and ketones. And when you burn glucose, you build up lactic acid, you build up hydrogen ions, and that collects in the heart tissue itself. And that creates a swelling. It creates a burn first, a muscle burn, which is what we call
Right.
angina or chest pain. And then if it gets to be too much, if it goes overboard, it can actually cause a heart attack with heart tissue death because it creates a swelling in the tissue, um, and and that swelling interferes with blood flow being able to get to that area, and it can create necrosis. So, and that has nothing to do with the plumbing or the pipes or the arteries, right? It has to do
Yeah.
with the stress response. And I can make an argument that most heart attacks are caused by that. And people will say, no, because I had a blockage that caused my heart attack. It's like, well, we don't know that. That
Mhm.
blockage could have been there for years and your body built collaterals around it. Then you started having heart attack symptoms and they go in with a heart cath and they find a blockage. They, oh, that must be cause, right?
Yeah.
And but we don't know if that was the cause,
Right.
but sometimes it is. I think blockages that when they happen so fast and acutely that there's no time for collaterals, that can be a cause of heart attacks. Definitely. But I think that we don't really understand, we don't have ways to determine which one it was, you know?
Yeah.
So, yeah.
It's really surprising for me as to the hypothesis that you're giving because being a doctor, what we are taught is the cholesterol hypothesis, right? And let's jump into that conversation, that controversial stuff right away, because I know some of the audience are here for it. You've been so vocal about challenging the cholesterol hypothesis for someone who's been told their whole life that high cholesterol equals heart disease. What is the fundamental flaw in that equation?
The main flaw is that they're trying to explain a whole complex disease process with one molecule, you
Mm-hmm.
know, and that's just not the way physiology happens. Like you can't explain. So there's this thing, this plaque that happens in the middle of the artery wall, and and they're trying to explain it by taking one element of blood, which is lipoproteins, LDL molecules, or various other lipoproteins, and they're saying that these things are creating this whole disease process by itself, or they're the main driving factor, you know, and that just doesn't make sense to me from a physiology perspective, from a nature, from a you know, the complexity of nature, you know, perspective, because there's lots of things present in the blood and present in the artery wall. So we have to look at, you know, water, and what water's unique ability to structure itself. We have to look at the fact that there's clotting factors in there, that there's a glycocalyx, and that there's inflammatory molecules, that there's electrolytes in there. There's all these things that are present in this space where we're seeing this plaque form, and we think it has to do with just this one thing. And you know, most physicians understand that there's an aspect of inflammation and those types of things, but they don't necessarily have a full understanding of the complexity of it all. And so that's just fundamentally flawed in
Right.
itself. Just that idea that, oh, if you lower this number, this LDL number, which has never been shown to be a driver of heart disease in the first place, we can talk about that if you want. But like, if you take that number, you just lower it, oh, now you're protecting yourself when you haven't addressed anything else about the complexity of this disease. All you're doing is lowering that number. And the thing is, 60, 70 years of treating that LDL number, that LDL cholesterol number with cholesterol lowering medications has not resulted in less heart disease,
Mm-hmm.
um, or less heart disease deaths. You know, the heart disease is still the number one killer in the world. We obviously haven't figured it out. Now, heart disease deaths have come down just a little bit since the 60s, but that has nothing to do with taking medications to lower cholesterol. That
Right.
has to do with the fact that we have interventions that can save people from dying from a heart attack when they're having, like, the reason I'm alive today. That's why we have lower, or we have a slightly lower death rate, is because we have those procedures like that. It has nothing to do with us taking drugs that's preventing anything. Because if you look at the studies on cholesterol lowering medications, they don't prevent heart attacks. Their benefit is very negligible as far as preventing a heart attack.
Right. That's incredibly interesting because I do have a lot of friends who are and family who are just held up on the fact that, I'm diabetic, so I will be taking the cholesterol lowering drugs, especially icosapent and, many other cholesterol lowering drugs. And even if they're not taking the drugs, all they're worried is my cholesterol below 200? And if I bring my cholesterol down, then I have no risk of heart disease. What is that we are missing? If cholesterol isn't the villain that we've been told it is, then what is actually driving, cardiovascular disease?
Well, what's driving atherosclerosis, which is what people talk about when they talk about heart disease, which I think atherosclerosis and heart attacks are quite different things. But what I think is driving atherosclerosis is mainly a lack of infrared light, a lack of infrared light exposure, because we're living indoors as a society now. The average person spends about 93% of their times either indoors or in an enclosed vehicle. And so without that exposure to infrared light, which comes from the sun, regardless if it's cloudy or not, like we're getting infrared light if we're outside during the day. That infrared light is what builds up structured water in your arteries and protects the arteries. And so if you don't have that exposure, then you don't have that layer of structured water that protects the arteries. Without the protection, then as a society, we've also added in um, a lot of toxin exposures and a lot of processed food diet exposures, things like that, that are now without the protection of the structured water, those things are now damaging the lining of the artery.
Mhm.
And when you damage the lining of the artery, it's supposed to be able to repair itself. And there's a normal wear and tear that's going to happen. But if it happens too excessively, or we have things in place that are preventing our bodies from healing the lining of the artery, which means we have an epidemic of type 2 diabetes,
Mhm.
because growth and healing of the lining of the artery happens with insulin signaling. And if you're insulin resistant, you don't get that signaling. And we have an epidemic of disrupted circadian rhythm because of artificial light exposure after sunset,
Yeah.
and just this imbalance in our light environment. So, and without that, we don't get the deep healing reparative sleep we're supposed to get at night. Even if you're unconsciously sleeping, you may not be getting that deep reparative sleep. And without that, you can't repair the lining of the artery. So then this damage happens. The body has a response to it, which is a clotting response. It has nothing to do with cholesterol, because if you analyze plaque, it's 87% clotting tissue, according to some literature. And so then the clotting response happens. Then the body can't heal the clotting response because of our epidemic of diabetes and disrupted circadian rhythm, and the plaque can build up over time, and it gets bigger and bigger and bigger. However, if that, just like Giorgio Beraldi's work showed, that if that plaque gets to 70% narrowed, the body will build collaterals around it. So having plaque in your arteries, to me, is not what's going to cause your heart attack. It's having blood that's too viscous, too thick,
Right.
that's going to clot too much, especially if there is plaque in there and it's disrupting blood flow and creating turbulent blood flow. That increases the risk of clotting.
Right.
So that acute clotting situation, or the nervous system response that we talked about earlier,
Right.
there's two different types of heart attacks. So yeah, I think that's the actual cause, is those mechanisms. So really, it's basically just our change in lifestyle over the last 100 years or so that's led to this epidemic of heart disease.
Mhm.
Because heart disease was present to some extent in ancient cultures and things. We know that the ancient Egyptians had plaque, and things like that, but it wasn't near the epidemic that we have today. So when we try and explain that, it's how our environment and lifestyles have changed over the last 100 years.
No, that's incredibly interesting to note, because more and more that I am diving deep into how the lifestyle is affecting the human body, we see that we're going back into our ancestral literature to see that, well, they did not die of heart attacks. They died of predator attacks, or, because, they died in a battle or something like that, but not of heart attacks, right? But here's what confuses people. We see studies showing that statins reduce the risk of cardiac events. And if it's not about cholesterol, how do you explain those results, and what are statins actually doing? And earlier, you were also saying that LDL is not the thing that we need to be scared of or afraid about.
So the studies that show that statins reduce the risk of a heart attack, don't actually show that. They mess with the statistics to make it look better than it actually is. So here's an example. So there's this one study called the Ascot trial.
Mm-hmm.
Um, and in that trial, they had a treatment group and a control group. So the treatment group took statin drugs, the control group did not. And first of all, they weed out the people who, like, before the studies even start, there's like a 6-week period where they start taking the drug, and the people who get side effects, they eliminate from the study. So they don't even include them. So
Mm-hmm.
the amount of people who had adverse events from the drug is inaccurately reported, because they weed people out before the study even starts. Then, when they start the study, what they found is that the people in the treatment group who took statin drugs had, in this study, had 98.1% of them did not have a heart attack. In the control group, 97% of people did not have a heart attack. So technically, the statin group was 1.1% better. Absolute risk reduction of 1.1%, which is not statistically significant. It doesn't matter. It's basically the same when you look at statistics. So you can't really say anything from that. However, in the study, what they do, like, the study claimed that they reduced the risk of heart attack. Statins reduced the risk of heart attack. And the way they make that claim is they report it as relative risk rather than absolute risk. And so what that means is they take, which this doesn't even make sense to do this, but it's just them messing with statistics so they get a better numbers. They take the 1.1% of people the difference between the two groups. They compare that to the 3% of people who did have a heart attack in the control group, and they say that gives you a 36% risk reduction,
Right.
relative risk reduction, which again makes no sense. It's not clinically relevant for them to do it that way, but that's what the headline says: 36% risk reduction. And every single statin trial does this. They mess with the statistics like this. And so there's a paper that was published, and they took 21. There's probably about 50 different clinical trials like this, but they took 21 of these clinical trials in this paper, and they reviewed them, and they found that when you report it as absolute risk, the benefits are negligible, and there's really no benefit to taking a statin as far as preventing a heart attack. And so that's a big issue as far as like the accuracy with which the statistics are reported. And it's really hard for the average person in the population to sort through all that. And even
Yeah.
cardiologists are not statisticians. They're not in there looking at that kind of stuff.
Yeah.
They're being like wined and dined by the pharmaceutical reps to say, look at
Yeah.
this study, this showed this, it looked 36% risk reduction. And they say, oh wow, that's amazing. I'm going to start using that drug more. And that's how it
Yeah.
goes. So unless the doctor actually takes the time and looks into things and learns about statistical manipulation and things like that, they don't really know the truth about what is going on.
No, that's completely true because the medical reps come with the study and they have everything printed out and they say, hey, doctor, we have drugs A, B, C, D, E, and this is the effect. We have studied it. And honestly, as medical professionals, we all don't have the time to go back and sit and look at all the peer-reviewed studies or probably do a systematic review because, patients are waiting and then we have to give them solutions.
Yeah, exactly. It's a very tough position to be in.
Yeah.
However, you talk to a lot of physicians and they'll tell you like, well, I did the best I could, but they still got a disease or they
Yeah.
still died of a
Yeah.
heart attack. It's like,
Yeah.
okay, well, clearly your approach didn't work.
Yeah.
So let's start thinking outside the box, and it is tough for physicians, and there's not a lot of time.
Yeah.
And and it has to be done. Like you
Yeah.
gotta find
You
the time, you
know,
gotta
uh,
prioritize it. But
you know,
it's tough. Yeah.
but Dr. Stephen, what I find very amusing and, interesting is that not a lot of physicians still know that statins are not good for the patients. A lot of physicians, even today, very, very strictly recommend statins. They very, very strictly put their patients on statins. With that being said, just taking the step outside to say and take a look outside the box is quite a challenging thing, and not many people can have access to that, right?
Yeah, it definitely takes a mentality, and lots of times it takes an experience. Like my experiences with health and how I was able to fix things made me start to question that philosophy. Whereas lots of people don't have that experience to kind of guide them. And yeah, it can be tough. And yeah, but it's necessary. And we're coming to a point now where it's just like it has to be, you have to think about it logically first.
Yeah,
Like heart disease is not a statin deficiency. That makes no sense whatsoever. It makes no sense that our body would be trying to kill us by
yeah,
making this molecule in our body that is so harmful for us or whatever. That doesn't make sense. And so cholesterol has been around since humans have been around,
yeah,
and cholesterol is even present in animals. Like animals don't get heart disease like we do.
yeah,
So why, why is it that we're getting heart disease in these bigger numbers? It's not just like, oh, you can lower this number and all of a sudden you're safe, because
yeah,
that's clearly not true. All you got to do is like, if your doctor's saying you have to be on this drug or you're going to die, you're going to say, okay, so if I take this drug, you can guarantee that I won't die of a heart attack. And they can't do that because people
yeah,
on statin drugs die of heart attacks all the time.
yeah,
So obviously it's not the solution. It's not preventing things. So we have to look outside the box. And if you just think about it logically for a minute, you'll realize that, hey, that's not the solution. Now I have to go find it. I have to go investigate what the actual causes of heart disease are, which is what I had to do for myself after my heart attack. And I was quite successful at it. So that's what
right.
I'm doing now.
So moving on, let's talk about LDL particle size and oxidation because I've heard you talk about pattern A versus pattern B LDL. Can you explain why not all LDL is created equal and what should we be actually measuring?
Yeah, I kind of think, and this is just kind of just to start off, I kind of think the whole conversation about measuring blood lipids should be kind of thrown out the window. And people argue with me that you can't just throw the baby out with the bathwater and everything. But at this point, I'm kind of thinking like it's a huge distraction from us figuring out the actual causes of heart disease.
No, I
So
completely
whether
agree with you on this. I completely, because my patients stress over cholesterol so much more that I'm just like, how are you going to live without cholesterol?
Yeah, exactly. Well, there's that, but then, you know, just taking the basic lipid panel, people are recognizing, especially in medicine, that's breaking down. Like you can't really assess risk of anything from that basic lipid panel besides looking at triglycerides with the trig to HDL ratio. That can give you some indication of if there's metabolic health, but really you can't diagnose it based off that. Otherwise, knowing what that number is completely useless. First of all, it's like one snapshot in time. So when people say my cholesterol is high, it's like, no, it was that number when you took it, right? When you took that test, but it's probably changed a million times since then, and it will continue changing. So we don't know what it is right now because it's not supposed to be a certain set level of anything. You know, it's always fluctuating based on when you eat, how you eat, the timing of eating, your metabolic health, all this stuff. It's always changing, and that's the way that it is. But then they want to measure all these subfractions. They want to measure oxidized LDL and particle size and particle number and ApoB and LP little a and all these different things. And all those things can tell you are some basic states about things. So if you have high or if you have small particle size or high oxidized LDL, that just means there's something causing inflammation in your body.
Mhm.
And that inflammation is damaging the lipid particles, just like it's damaging other things in your body. But that doesn't mean the lipid particles are causing heart disease. It means the things that are causing the damaged lipid particles are also causing heart disease, which is why you can take oxidized LDL and it's associated with higher rates of heart disease, not
Mhm.
because it's causing it, but because there's something else that's causing both of those things. Or LP little a has to do with clotting. And so if you higher LP little a can prevent the breakdown of clotting tissue, making it more likely to develop plaque. There's ApoB. Everybody wants to argue about ApoB. And a certain percentage of your LDL molecules are going to be of the ApoB variety. And there's studies that show that one, if your LDL goes up, your ApoB will go up just by default because a certain percentage of them are going to be ApoB. So if your LDL goes up, by default, it's going to go up too. And ApoB is generally can become higher in people who are metabolically healthy. So is it the ApoB that's causing the issue, or is it the poor metabolic health that's causing the issue?
Yeah.
And the insulin resistance, which we talked about insulin resistance being a driver of like decreasing the body's ability to heal clotting tissue once it's formed. So there's so much nuance here, and you can't say, oh, my blood work is good. I'm not gonna have a heart attack. Or I'm not gonna develop heart disease. Guess what? My blood work looked great, and guess what happened to me? I had a heart attack. You know, so yeah, it's we can't look at those things because health is not making your numbers be a certain thing. Health is the signals your environment is giving your body and surrounding yourself with signals that signal to your body to be healthy or to express health. So if your body is expressing poor health, it's getting the wrong signals. We have to give it different signals. And if you look at the way that life has changed for humanity over the last 100 years, it makes sense why we're getting disease because we went from living pretty much out in nature all day long, um, and uh, and like having even if we lived indoors, like in the 1800s, 1700s, things like that, heart disease wasn't as crazy as it is now. Why? We've changed our light environments. We've increased the amount of toxins we're exposed to. We've living sedentary lifestyles where people are sitting behind computers all day long. We've eaten more processed foods. We've introduced a lot of processed grains, sugars, and vegetables. We've done all these things that completely changed our environments, and there's no way our bodies could have adapted to
Mhm.
that. And it's showing up in all forms of diseases, but one of them being heart disease. So that's what I say. Like we made all these changes, these things that are causing heart disease, and we think we can just take this medication to lower LDL and that's going to fix it. No, you've got to change your environment, change your signals. That's what's going to fix it, or reduce your risk. So yeah,
Yeah. No, that's pretty comprehensive because today, if I were to ask you, someone gets their blood work back and their doctor says, your cholesterol is too high, you need statins. What questions should they be asking and what tests should they request to get a full picture?
sure. I mean, I'm not huge on testing. I don't think that it's really that useful. Or I mean, there's a few things that can be useful, but that is like testing doesn't tell you what to do, and the reason that doctors don't take a lot of the testing that I would want to see is because they don't know what to do about it, right? They
Right.
don't know how to fix it. So if you get a fasting insulin level, which most doctors don't order, they don't want to order that because if it's high, they don't know how to tell you to make it lower. So well, they don't know they can't do it. Or a leptin level, same thing. If the leptin is high because you're leptin resistant, they don't know how to make that lower or what to tell you to do. They don't have a drug that can make your leptin lower or your insulin lower, so they don't test for it. things like that, but generally tests that are more useful are this like inflammatory markers like HS-CRP or an insulin level or a leptin level, those types of things. But even then, like all that stuff just tells you a certain thing of information about what it was at that point in time. It doesn't tell you what to do about it because, like, to me, let's say you got your insulin level, and it was high, or let's say it was normal. Whether it was normal or it was high, the answers to making it lower if it's high or keeping it normal if it's normal are the same things. So let's just do those things. We don't need to take a test. So testing is really only beneficial if it dictates your treatment. Like it tells you what to do, like do this versus that, right? Which is in emergency situations, testing can do that. It
Right.
can tell you exactly what to do. But in a chronic disease situation or a preventative health situation, like it really doesn't tell you what to do or dictate your treatment.
Mm.
Testing can also be useful if it motivates somebody, like if their testing is way off, so to speak, and that motivates someone to change. That's useful. Or you can use testing like you get a baseline and then somebody makes a change and you see a difference in testing that motivates them to keep changing and keep doing the behavior. Like that can be useful in that sense, but it really doesn't tell us much about risk of disease, in my opinion. And that goes for imaging,
Mhm.
cardiovascular imaging. That goes for blood tests, things like that. All that stuff doesn't really help us assess risk from my perspective. What determines risk is your environment and your
Right.
behavior. Those are the things that you really need to focus on. It's not about trying to like change things so that my testing looks perfect. It's about creating an environment that gives your body the right signals. That's what's really going to determine your risk.
So, is it safe to say that, for example, if someone is always stressed at work, running late to work, or, just stressed around with kids and families, and, they're going through a divorce or they're going through a tough time in their life, a financial crisis or a job loss or anything as such, does that increase their risk of cardiovascular events?
Absolutely. Yeah. And the literature is very clear on that, like going through stressful times in life. However, what helps us go through those times without suffering from major events or increasing risk of heart attack is the things we do, like the other things we do, like increasing your infrared light exposure, setting your circadian rhythm, being in contact with the earth, developing positive, loving relationships and a good social support system, decreasing toxin exposure, making sure your dental health is clean, there's no dental infections. Like all this stuff is very, very important so that when those stressful times in life do come, because we're not going to be able to avoid them, you know, then we've done a lot of things that protect us. So you got to think about it like, we all have a metaphorical bucket. And if that bucket, there's lots of things that are going into the bucket as far as things that can contribute to disease. And then when the bucket overflows, we get symptoms. So if we keep as many things out of the bucket as we can, then when that stress comes that we can't get rid of and it goes into the bucket's not overflowing now. So that's what it's about. The problem is that most people don't understand all the aspects of our modern way of life that are contributing to disease, specifically heart disease. From my perspective, that's what I work with people doing, is helping them become aware of those things so they can change them. Because what they're getting from their doctor is you have to take this drug or else you're going to die. And they say, well, what else I can do? And the doctor's like, I don't know, eat less saturated fat or eat a better diet or whatever, whatever they say. And those things are not helpful. It's very fear-based thinking. Take this drug or you're going to die, instead of empowering the patient and saying, listen, here's the things that contribute to heart disease. Let's make sure that none of these things are a concern for you, or if they are, let's try and figure them out. That gives the patient something to do. It makes them proactive. It gives the
Mhm.
power back to them, gives them an internal locus of control. And that's not being done because doctors aren't trained in those things. They
Right.
don't even know to tell you those things.
Yeah.
And that's just the philosophy of medicine.
Right. I completely agree with you on this because we have just not been taught about this in the philosophy of medicine because we are taught to act on signs and symptoms and not root cause, even if we were to look at it, right? But apart from that, moving on, extensively written about seed oils, oxidized lipids, and their role in heart disease. And this is a hot topic right now with a lot of people saying, it's okay, whatever oil you eat. And then there's also a debate saying that seed oils are good for you, not good for you. You change oils every month, and there's so much. Why should we be more worried about the case of vegetable oils in our kitchen than saturated fat in our steak?
The first thing I'll say is from a logical perspective, humans have been eating saturated fat in animals since humans have existed on this earth. However long you believe that is,
Yeah.
we've been eating saturated fat from animals. Heart disease is a new thing. In the epidemic we have it, it's a new thing. So it can't be that. Like that doesn't make sense to make that claim, right? However, seed oils are a very new thing. They've only been around. They're man-made, and they've only been around since the early 1900s. And they've only been around in consumption of like the quantities that we're consuming now, especially in westernized countries, even shorter than that. So, from a logical perspective, it doesn't make sense that the fat we've been eating most of our lives as humans, most of the time humans have been on Earth, is causing a disease, and this new thing we've introduced is not causing it that or contributing. I can't say that there's one cause. So that doesn't make sense. Now, from a more scientific perspective, if you look at the fact that these seed oils are polyunsaturated fats, right? So they're not saturated with carbons, which makes them unstable. So they're very prone to oxidation from things like light and heat and oxygen. And so when they get damaged like that, then they become this inflammatory thing, and then we're ingesting that thing, or we're ingesting those oils, even if they haven't been damaged yet, we're ingesting them. And let's say we're inflamed on the inside. Now they're getting damaged once they're inside of us. And
Mhm.
that contributes to um, this inflammatory issue that happens, these inflammatory oils and things. And so the inflammatory issue is one of the main drivers of damage to the lining of an artery, or depleting nitric oxide,
Mhm.
which is one factor in the nervous system response to that can cause a heart attack. But the other issue with seed oils, and with plant fat in general, is that we are animals. We use animal fat. We use cholesterol. Plants use plant fat, which is called phytosterol. And so we can use phytosterol in a pinch, like if we need to. I liken it to, like, the analogy I use is like building your body and using saturated animal fats is like building your house of bricks, right?
Right.
Whereas you can build a house with plant fats, but it's like building a house of straw. You can do it, but it's just not as like solid. It's not as sound as building it with bricks. So, and there's plenty of research to suggest that if we have to use more plant fats, more phytosterol to for the formation of, or the structure of the red blood cell membrane, it makes the red blood cells very rigid and not flexible, which is the bad thing, because when the red blood cells have to squeeze through tight places in the capillaries, it can create damage. And there's actually literature, mostly in animal models and rats, where feeding them vegetable oils increases their risk of stroke, because the red blood
Right.
cells are trying to squeeze through these things, and it creates stroke. And there's studies that show that people like vegetarian diets, where they're eating lots of plant fats, because they're not eating animals, that have higher risk of stroke. And
Hmm.
these are just associational studies, but it's interesting. There's also studies that show that people who ate higher amounts of plant fat, phytosterol, also that plant fat was getting deposited around the valves of the heart. It gets stuck in places because the body doesn't use it very well. It doesn't use it like it does cholesterol. And so yeah, I mean, there's concerns with that, but it makes sense from a perspective of we are animals. We use animal fats. Plants use plant fats. And so, yeah, we just have to be cognizant of those types of things. Is it even compatible with our physiology, or are we just using it in a pinch?
Mhm.
Not to mention all the inflammatory things that can happen when we get damage to those oils too. So, yeah.
So yeah, I mean, I'm quite not so surprised by your analogy, but also cardiologists tell us that, veganism is what is best for your heart. And now there is this whole body of work that, says that animal fat is bad for you and you need to be vegan in order to be healthy. And, that's what is the best thing for humans because plants are what we need to eat. And also another big analogy that the kind of meat that's good for you is not red meat. So, what do you have to say about that?
Yeah, so most of the studies that make those types of claims are studies that are associational studies. So what associational studies mean is that they're just seeing two things happening at the same time. They're seeing, like, you could say someone eating more red meat and higher incidence of cardiovascular disease. and they're just seeing them happen at the same time. But one, you can't say that seeing them happen at the same time is proving that one causes the other, right? So the
Mhm.
analogy I use is like if you're standing on the sidewalk and you see a traffic jam in front of you, and you also see that the sky is cloudy, you can't say the traffic jams cause the clouds or the clouds cause the traffic jam. You're just seeing them happen at the same time. You'd have to do studies to test, like if we create traffic jams, does the sky always get cloudy or vice versa? And so, yeah, so that's one issue, is that it's just showing an association. The other thing is that, you know, you can't account for all the different factors that are going on there. Like there's this healthy user bias. So like if somebody's trying to be healthy and they're listening to all the government organizations and the
Mhm.
academic institutions telling them don't eat red meat, like they're trying to be healthy, which also it's much more likely that this person trying to be healthy is also exercising and getting more sun and not drinking and not smoking and all these types of things, reducing their stress. So and they're also eating less red meat because they're trying to pay attention to the guidelines and trying to do those healthy things, right? So is it the eating less red meat that's making them healthy, or is it just that they're also doing all these other healthy behaviors? And vice versa, if somebody's not paying attention to any of the recommendations from these government organizations or academic institutions, and they're eating whatever they want, which includes more red meat, that red meat they're eating is probably coming from fast food and other processed foods. They're also less likely to be exercising, less likely to be are more likely to be smoking and drinking and all these doing unhealthy behaviors. So you can't say that them eating more red meat is what caused them to have poor quality health, because there's all these other factors and you can't account for that. The other thing is that these types of studies are based off food surveys. They give people surveys and ask them, how much of this have you eaten in the last year?
Right.
How are people really supposed to remember that? And there's studies that actually show that using surveys is a very inaccurate way of reporting things. And
Yeah.
so all these studies are not very high quality. They're called epidemiological studies, and they're the lowest form of research for a reason, because you can't really draw conclusions from them. However, most of the recommendations from government organizations and academic institutions are based off of these associational studies. So, yeah, and then logically, again, we have evidence that humans, the first modern humans and Neanderthals, were eating almost extensively animal foods. They were apex predators,
Yeah.
and we have that archaeological evidence. We have that from dating or from analyzing the nitrogen amounts of nitrogen in their bones, things like that, that they were apex carnivores. So yeah, if that was so problematic for humans eating this meat, we wouldn't have made it. We wouldn't have made it as a species. So yeah, it doesn't
So,
really make sense. It doesn't even stack up.
so the next question is what counts as processed meat and how much of, red meat can one eat? Is it like all they can, or is there a limitation to it? And how does one quantify the amount of meat that they should be eating?
Well, I don't think it's useful to put such parameters on things. I think if you're eating the right foods, your body's going to tell you when you're satiated. That's the problem, is that we're eating foods that don't satiate us. And so I think diet has been a giant distraction from the actual causes of heart disease. I do think a good whole foods diet is important, with less toxins, but it's been a giant distraction from what's the actual causes of heart disease are. People think they can control heart disease or prevent it by diet alone, and that's not true whatsoever. But yeah, so I don't like putting parameters on, oh, yes, you can eat this amount of this or this amount of that. Like eat whole foods and eat foods that are satiating, and your body will tell you when you're done. And so what does that mean? Because like if you're hungry, your body is looking for it's if you're hungry, if you're pathologically hungry, it means that your hormones are off, which means you need to set your circadian rhythm. And that will set your hormones. But if you're hungry, like you're getting a hunger signal and it's a healthy hunger signal, your body's telling you it wants nutrients and it wants energy, right? So for one, nutrients are proteins, vitamins, and minerals. Energy comes from either fats or carbohydrates in food or from sunlight exposure and contact with the earth. That's where energy comes from. So if you're hungry and you're not satiated, you're lacking something there. So when you eat a food, you want to make sure that that food gives you protein, vitamins, and minerals, and an energy source. So that could be, I mean, the ideal food is steak, is red meat. That satisfies all those things. And we have human history tells us that that's what humans primarily ate, was red meat. So that's the best food for humans, in my opinion. So when you're eating a food, though, you want to make sure it's very nutrient dense, proteins, vitamins, and minerals, and it gives you an energy source. So what are the two things that we would have had in nature? We would have had animal foods to eat, whether that was eggs or red meat or chicken or pork or whatever it would have been. We would have been hunting animals. And in season, we would have had fruit, right? Fruit is nutrient dense, doesn't have quite as much protein, but it has some. But it's nutrient dense and it has an energy source. It has carbohydrate. Those are the things that we would have eaten as humans, if we lived in nature, right? And then it wasn't until we invented agriculture that we started getting things like grains and sugars and vegetable oils and various beans and things like that. Like those things are not ideal. Like, are they the worst thing in the world? Depends on how you process them and depends on things. But those are not ideal foods for us as humans. Like we should stick to whole foods that were available to us or have been available to us for a long time. So to me, that's, I say center your diet around animal foods. Make sure it's whole foods, and then create variety with plant foods when you want to, whether that's fruit or vegetables. But I eat primarily animal foods. And then in season, I'll have some plant foods when they're available locally. So yeah.
Okay, that's a fair take on it because I think it also depends on I think our own ancestral history as to what foods
Mhm.
we were kind of eating, because I've also read a study wherein, there's this specific African tribe which has the best gut microbiome because they are a tribe that walks around and they eat anything and everything, and they have about the highest diversity, their gut microbiome, and forget what the tribe is, but I think that's what it depends on, to kind of eat more variety of food, if that's what you're saying, rather than, just stick to one type. Is that what you're trying to say here?
I would say that it's eating what's local to your environment. Yeah, and I don't necessarily think that eating a variety of foods is necessary. It may diversify the microbiome more, and technically alpha diversity of microbiome or microbes in the gut means that it's healthier. But you could eat many different diets that create diversity. There's studies in animals that are showing that like carnivore animals have just as much diversity as vegetarian animals. So it's not necessarily about eating a variety of foods. It's eating whole foods that create the diversity, and your bacteria will shift. Even if it's different bacteria, the diversity is still there. It's just a different set of bacteria based on which foods you're eating, and that's what I want. That's what I would want, is to maintain that diversity. So the real issue with like gut microbiome is that we're consuming so many things that kill off species of bacteria. So whether that's antibiotics or various toxins that act like antimicrobials, things like that, we're creating this issue down in there, and then the opportunistic species start to overgrow. We get this monoculture in there. That's the bigger issue. And the way you change that is you change your diet. You eat a whole foods diet. And yes, eating more diversity of things could create slightly more diversity. And that's why I think like eating seasonally is important. Like
Right.
plants that are available in winter versus in summer, like and changing throughout the year is important. It's okay.
Yeah.
Um, so yeah.
So moving forward, since we spoke about a lot about, what is that's causing heart inflammation and everything, everybody just throws around inflammation as a buzzword. What does this actually mean? Should we be tracking our inflammatory markers? And, because I do see very commonly that now we talk about HS-CRP and ESR and things like that, and we want to track those markers, right? Does this actually help, or is it just those one tests that you want to have and then see how to kind of bring it down? And how do you actually bring this inflammation down?
Yeah, so again, those tests are just one snapshot in time. Like you take your ESR, you take your C-reactive protein, or all these inflammatory markers you could take. There's some you can really get into the weeds with them.
Mhm.
Um, you could take those, but again, the solutions to making them normal if they're abnormal or keeping them normal if they're normal are the same things. So you
Mhm.
might as well just go and do those things regardless of what the number is. And what are those things? So all those things, like when you think about inflammation, what does inflammation mean? People use a lot of words. They use inflammation, they use oxidative stress, yeah, things like all these different buzzwords. But all it really means is your body is low on charge. Your body wants to be charged up. We are basically big structured water batteries that require a charge. And the things that charge us up are sunlight, direct contact with the earth, and we can harvest the chemical bonds and the energy from the chemical bonds in food, and we can use that for energy and charge, right? So those are the things that charge us. So if your metabolism is broken, you're not getting infrared light, you're not being in contact with the earth, and you're also in contact with things that steal charge, like non-native electromagnetic fields, like wireless signals and electricity, electromagnetic fields from electrical in the walls, things like that, or toxin exposures. Those things can steal your charge. And so if we really want to decrease inflammation, we have to increase the charge by getting more infrared light exposure, getting more contact with the earth, optimizing our metabolism by eating a whole foods diet that's getting us adequate, clean sources of energy, and then eliminating the things that steal the charge.
Right.
That's the name of the game right there. People want to take these anti-inflammatory things, or they want to take these supplements that are um, antioxidants, so to speak.
Mhm.
And yeah, those may help very temporarily if you take one. I haven't really seen anything too substantial as far as literature that shows that they're that anti-inflammatory when you take them as a supplement or in a
Mhm.
food. The real way you create less inflammation is you give your body the right environment to absorb energy to it. All life is just trying to absorb energy from its environment to use it to create order in our bodies. If it
Mhm.
doesn't have enough energy, it can't create order. We call that disorder. We call that disease. We call like inflammation. We call it oxidative stress. That's all that it is. So we have to put our bodies in the right environment so they can absorb energy.
Right. That's really, really actionable, I think. And if you were to put out like 5 actionable principles for cardiovascular health, what would that be?
Number one, first and foremost, is get more infrared light. Technically, humans are supposed to be outside in infrared light all day long. So the more infrared you can get, the better. So that means sunlight. It could be infrared sauna, red or infrared light panels, things like that can be helpful. Number two, set your circadian rhythm, which means optimizing your relationship with the cycle of the sun, giving your body very clear signals of when the sun is up or down. And the main issue there is artificial light, whether that's screens, whether that's overhead lighting, any artificial light is disrupting our circadian rhythm and telling our body it's a different time of day than it actually is. So syncing that up is a very good idea. I would say reducing your toxin exposure. So this goes from plastics to heavy metals to herbicides and pesticides. There's lots of different things that are contributing to damage to the lining of the artery that we should remove. I would say a whole foods diet is very, very important. Eating whole foods as close to like centering your diet around animal foods and then eating plant foods in season when they're available. And then lastly, I'd say more of like an emotional or energetic health, whether that means
Right.
addressing past trauma, surrounding yourself with supportive, loving relationships and eliminate toxic relationships, all those sorts of things. I think that is very, very critical as well.
Right. The next thing that I just want to address is that we were just talking about cardiovascular events. Now, there is also blood pressure that we are known to cause heart attacks and things like that. We're put on ACE inhibitors, beta blockers, ARBs, and are we over medicating? What's the functional medicine approach to hypertension?
Yeah, I don't think that there's any evidence that high blood pressure causes heart attacks. I
Mm-hmm.
think if somebody has high blood pressure, the things that are causing high blood pressure are also contributing to higher rates of heart attacks. But that doesn't mean that high blood pressure is causing heart attacks. I mean, if you think about it, if someone has high blood pressure, we don't tell them not to exercise, which
Yeah.
is going to create even higher blood pressure if they exercise momentarily, right? So I don't think that that's the case. And yeah, so and technically, if you look at Framingham data, like high blood pressure is really only dangerous and associated with higher rates of disease if it's 70 to 80% above what's normal.
Mm-hmm.
So, which means that slightly elevated blood pressure is not a problem, and yet people are being medicated for it. We're over medicating for blood pressure. And the studies show that when you medicate people for blood pressure on medications with blood pressure that's slightly above what's normal, it's not having a benefit. And matter of fact, it's causing harm as far as like increasing the risk of death, especially as we age. Like people above 60, if they have lower blood pressure, like lower than 130 over 90, then they have increased risk of death because as we age, we need more perfusion pressure. We need higher pressure to deliver oxygen and nutrients to the tissues, and we're driving that down. Driving it down also increases the risk of falling because of low blood pressure increasing the risk of fainting. So yeah, I think that there's a huge conversation to be had about that. I think the whole salt and blood pressure thing is never been substantiated with the literature. Matter of fact, higher salt has been shown to be protective as far
Mm.
as for insulin resistance, and insulin resistance is the main cause of high blood pressure. I think that we've gotten it all wrong there, and we're over medicating people. And then lastly, with cholesterol and with blood pressure, the recommendations for what those should be have been changed throughout the years. They keep moving the goalpost of what it should be. And like when they first decided cholesterol was bad, they said that LDL should be 250 or lower. Then eventually it was lower to 200, then 150, then 100. Now they say 100 or lower. And it's just there was no evidence for that. It was basically driven by the pharmaceutical companies saying we want it to be lower because the lower it is, the more people would need the
Need the
medication.
medication.
Same with blood pressure. They lowered what the recommendation was that would constitute what high blood pressure is. And so the lower that is, the more people would need medication, even though medication for mildly elevated blood pressure is not been shown to be helpful whatsoever. And in some cases in older people it's been shown to be harmful. But the biggest issue with all that, like there's all those issues there. The biggest issue is that approach, trying to make your blood pressure this number, trying to make your cholesterol this number, are huge distractions from what the actual causes of heart disease are. Now we're not addressing those things. We're not addressing the fact that we're not getting infrared light. We're getting toxin exposure. We need positive, loving relationships. We're not grounding. All those things are way more important than trying to make these numbers what they are.
Right.
And that's getting lost when we're trying to obsess about those numbers and even arguing if it should be this versus that. It's not the point. It needs to be
Right.
something else.
Right. I think that's very, very important. I think for someone who's diagnosed with hypertension, when do you think they should be worried at all, or should they about taking these drugs or about, starting on antihypertensives or anything at all? Even if somebody was to say, diagnosed with a cardiovascular disease, do you think can they get off antiplatelet drugs ever? Because as a medical industry, we tell them that your antiplatelet drugs are going to be with you forever.
It all depends on the person. It all depends on the person's philosophy and what they learn and their confidence, right? Because I could tell you ways to prevent clotting from a biophysics perspective, and if you're confident that you're in that environment enough that you don't need this antiplatelet medication, then that's up to you, right? I can't tell you to take or not take anything. That's up to the patient. It's not up to the doctor. It's not up to the patient's spouse. It's up to the patient on what they do. And so all I can do is give information that helps you make that decision. Whatever decision they make is the right decision for them. So same with blood pressure medications. If I give you information that helps reframe that for you and you decide, I don't need this, that's your decision. But you have to do your homework, and I'm trying to provide information as best I can so that people can make more educated decisions about those things. But I do think the one thing I do know for sure is that using these medications as the primary approach to preventing cardiovascular disease is not working,
Right.
because it is still the number one cause of death in the world and the number one incidence of disease by far. It's not even close. It is the number one cause of disease, and cause of death. So yeah.
So tell me this, Dr. Stephen, if I was supposed to be diagnosed with hypertension and I want to be off my hypertensive drugs and I also have a stent in my heart, what do I do?
I mean, you decrease the risk of clotting from biophysical. I can't tell you what to do, but I can tell you what I would do
Yeah,
if
what
I
would
was
you
in that
do? What would
situation,
you do?
right? I would decrease my risk of clotting from a biophysics perspective, which means getting as much infrared light as possible. It means putting my feet, making myself grounded to the earth as much as possible, avoiding toxins, avoiding non-native electromagnetic fields, which means wireless signals and energy electromagnetic fields from electronic devices and things like that. Yeah, it's about you know, it's about staying active and moving. It's about restoring communication in the body through resolving past trauma and surrounding yourself with a positive social network of friends.
Right.
All those things are very, very important. Like that is the way you prevent clotting. There's a very biochemical way to prevent clotting from like a stent in there or viscous blood or whatever, which is a blood thinner or an aspirin or things like that. Those can create this biochemical thinning of the blood. But guess what? People on blood thinners and on aspirin still have heart attacks. They still get
Yeah.
clotting. They still have developing plaque, which means we haven't addressed the real cause. or you can do it from a biophysics perspective. And the biophysics perspective of how you prevent clotting is making blood thin from a non-coagulative perspective, which means you're charging the body. You're getting energy to the body so that the red blood cells are not sticking together. You're creating blood flow by getting sunlight and grounding, which creates structured water that creates the movement of blood, which prevents it from clotting if it's moving, right? And you protect the lining of the artery from damage and inflammatory responses by, again, building structured water by getting sunlight and grounding, which again, it makes sense. That's where humans are supposed to be. That's where all life on the planet is outside in contact with the earth under infrared light all day long, and humans are not. And so without that stimulus, it's no wonder this is happening. It makes sense.
It completely makes sense now that you're saying it because we see it all the time, and I think we just forget to realize that, right? And last but not the least, there are a lot of cardiovascular supplements, especially things like CoQ10, magnesium, vitamin K2. Do we take these? What makes your list?
I'm not huge on supplements. I do think they can be used like to supplement the lifestyle. There's a reason they're called supplements. They're supplementing the lifestyle. So if you're taking them thinking, oh, this is protecting me from this or that, that's not true. It only does that in the context of the lifestyle. So if you make your environment ideal, then the supplement could enhance that. You can give yourself a little bit more vitamin K, or you can give yourself some CoQ10. But you could also just eat beef liver and get both of those just fine without having to supplement, and it's always going to be better from food. So yeah, but like supplements aren't going to create health.
Yeah.
They may push it along a little further in the context of the right environment and lifestyle. That is the most important thing. We have to change the signals our body's getting.
And moving forward, there are newer interventions like, enhanced external counterpulsation, ozone therapy, peptides like, BPC 157. Are these any worth exploring?
Yeah, I mean, all those things can be seen as like little biohacks or things like that. And we're living in this world where we're trying to optimize our physiology through these biohacks. But the real biohack is getting back to nature. Like you can do all the BP57 you want, or 157 or whatever it is, or you can do all the PMF therapy that you want, or all these things. But if you do those therapies and you go right back into the environment that's creating poor health, is that really useful? I would say no. It may be useful momentarily when you take that, but unless you go optimize the environment, your body's just going to get the same signals to express poor health. You can't heal in the environment that made you sick. You have to change that environment. And that's hard to do for a lot of people. So all we can do is within the confines of our modern way of life, create an environment that's more as close to nature as possible, and give ourselves stimuli by things. And the further away you live from nature, like in the middle of a city, the more you have to rely on those types of devices and things like that.
Yeah.
The more you can get access to, things like nature, like a city park or whatever like that, the better your health is going to be. And I know it's not the answer that everybody wants all the time, because they want to know, oh, what can I buy? What can I go out and buy and take and do these things that don't have to change anything? And that's just not going to work.
Right.
You got to change the environment. So yeah.
Right. And the last question, I've recently been reading a study which was published in the American Cardiology Association that melatonin is what is causing heart attacks, and it's causing increased number of heart attacks. And I know a lot of people who have benefited from melatonin because their circadian rhythm was so bad or they just couldn't fall asleep. But what is your take on this?
I mean, melatonin, it's really counterintuitive to say that, because melatonin has been shown to stabilize rupture-prone plaques. It's been shown to heal the lining of the artery. It's what optimizes our sleep, that helps set our circadian rhythm and balance our autonomic nervous system. All these types of things. Melatonin is huge for that. It's one of the most potent antioxidants in the body, as a hormone. It can do that. So yeah, it doesn't really make sense that someone were making that argument. It's also something that the body just does naturally. We get most of our melatonin production comes from near infrared light exposure from sunlight. So we need to get more sunlight. And then the amount of melatonin that sets our circadian rhythm comes from the pineal gland in response to darkness or lack of blue light signal. So that's just what happens naturally if we sync ourselves to the day-night cycle of the sun and be conscious of artificial light. So it doesn't make sense that melatonin would be causing those things. If I don't know
Do you
what
think
case
melatonin supplementation would be causing these things? It basically
may
measured that people who took melatonin supplements had a higher risk of cardiovascular events.
potentially, but why is that though? Is it because of the melatonin you're taking, or is it because this person, people taking melatonin usually are people who have trouble sleeping,
Yeah,
right? So they have trouble sleeping. There's something about their environment that's creating trouble sleeping, and that's what's causing heart attacks. So they're having to take melatonin to get any sleep whatsoever. So it's not that they're taking melatonin, it's that people who are taking melatonin are also people who are having trouble sleeping and have other things in their environment. So those things are what's creating the increased risk, not the melatonin itself. Does that make sense?
yeah, that makes
That's
complete sense.
that's an
Yeah,
issue. That's an issue with associational studies. You can't say, oh, people who take more have a higher risk. That must mean melatonin is the cause. Like, well, no. If what else? What is it about people who have to take melatonin that's creating the risk, right?
yeah.
Yeah,
Yeah, I think that really is, a lot of times we do read studies that are either systemic reviews or either like an association study, and suddenly there's this huge blow up that, oh no, this is suddenly bad, right? And that
right,
happens all the time. And for the general population, what it seems like is, okay, so the American Association of Cardiology said it, so it must be true.
right. Yeah, it's that appeal to authority.
Yeah. And I think, that's what most of us get wrong. And that authority is what most of us, want to kind of feel safe about because we do think that, they are a body. But also there's a darker truth that all of this is funded by pharma industries.
Right. Yeah. And they're trying to come after these supplements because they're not pharma, and that takes
Yeah.
away from their bottom line. That's just the nature of the industry. It's just we have to be educated consumers. That's all we can
Yeah.
be.
Yeah. So just to end it right now, what's your personal health protocol like, and what do you do daily, weekly to optimize your own cardiovascular health?
I mean, it's a lifestyle. It's not like I don't think of it as, oh, I got to add all these things like to make my health optimized or whatever. It's just what
Right.
I do. It's not like I do this for my health. It's just the way I live my life. It's a lifestyle. So, I wake up and see sunlight first thing before any artificial light. I eat first thing in the morning, a high protein meal. I make sure I stay hydrated with electrolytes. I don't do caffeine before food. I get plenty of sunlight throughout the day. I avoid toxin exposure at all costs by using the least toxic forms of everything, from laundry detergent to cleaning products to things I clean my body with. I get the least toxic versions of everything. I stay active. I go spend time in nature. Like it's just what I do. It's just who I am. It's what I do. And you have to kind of build that lifestyle,
Mhm.
to do that kind of stuff. So, yeah,
Yeah, I think that's supremely important. And for people who can do it and who have the time to do it, I think just at least getting that sunlight in the morning, especially for people who live in colder environments in colder countries, it's super important that, that little sunlight that's coming, whether it's cloudy, gloomy, whatever, just to get that, right? Because that fixes a lot of things in the circadian rhythm, right?
yeah. It's just take baby steps. Do one thing at a time, master that, and do the next thing, and do the next thing. You don't have to change everything all dramatically unless you can, unless you want to.
Yeah.
But just taking baby step makes one change at a time, make that a routine, do the next thing, and make that a routine, and do the next thing. Just keep adding to it until eventually it's just your lifestyle. It's just what you do.
Yeah, I think that's a very, very important thing to take away. And is there any message that you want to share to the viewers that you want to say by closing off?
Stay curious, right? You see new information or information that contradicts your current worldview. Um, you know, don't judge it. Stay curious about it, even if it doesn't end up changing your worldview. At least look into it. Stay curious about it. That's how we learn. That's how we grow.
Yeah, I think that's brilliant. Thank you, Dr. Stephen, for giving me your time. I know it's been a great pleasure talking to you, and hopefully someday we do a podcast in person. But until then, I mean, I would love to keep in touch and then see how to take it from there.
For sure. Yeah. Thanks for having me on.
Thank you. Thank you so much.